Good morning. It has been so wonderful to have you all here at Drexel and to be able to benefit from all of the wonderful work that everyone has been doing in urban health, and it's been very exciting for me. I'm also very excited to talk about community engagement and to make sure that community is in the center of community action in urban health. So why talk about it? I hope that I don't need to make this argument to you, but let's just make sure we're all starting from the same page. First of all, we know that our behavioral change interventions in public health have had limited or mixed results. It is very hard to convince folks to change their behaviors, and that's particularly true in lots of areas, but diet and exercise is one of those. We have wonderful promise, as we've heard all morning, that I am very invested in as well, in changes to the environments in which people live, work, play, and worship, but we also know that those benefits are also not always conferred to every population, and that our intractable and worsening disparities make it so that those improvements are happening less often and later in these kinds of urban environments where disadvantage is clustered, and the benefits of those are being seen later, if not at all. However, a lot of wonderful recent research around community-driven solutions have shown that community-driven work can really have a lot of promise in making this kind of intractable change. And I think common sense tells us that when the community is telling us what the solutions should be to the problems that they experience, it has the greatest potential to be adopted by their residents, and it also has the greatest potential to evolve with dynamic communities, as we've been talking about all the demographic shifts that we see in our cities. Also, a lot of research in social cohesion, civic engagement, and empowerment has shown us that community engagement itself can have positive health impacts on mental and physical health. And so just being an agent of positive change in your community can have its own health benefit. And yet, despite the Affordable Care Act mandated community health needs assessments and community health improvement plans, we still see that community action, which I really see as a series of, sort of the IOM collaborative planning and public health action iterative model of, assessing community needs, program development and implementation and evaluations of program impact. They're still largely not led by the community. They're better partnered with the community now, but they're still not being led by the community. And there's lots of really good reasons for that that we have been studying and I've been very concerned with and that we're trying to overcome. There's a skills mismatch. Folks in the community have the community history, context, understand the political nature of organizations and historical tensions in the community. They have the credibility to do the planning and the research. But unless they're in very large and savvy community-based organizations or nonprofits or local health departments that are also located in those communities, they typically don't have the time to learn these planning processes and evaluation and assessment and other research methodologies. At the same time, academics and researchers and planners have had all of that wonderful study, as we teach to our students in class. But they don't have the history and the context and the credibility to do the planning work, to do the research in the community. So there's a skills mismatch. And of course, that's troubled by the fact that, of course, we know that there's a long history of collaborative tensions. I used to call this town gown, but the tensions are more than just academic community tensions. That very well-deserved history of mistrust between academic institutions and researchers and communities, especially disadvantaged communities. But those tensions also now exist between hospitals and communities, which has a lot of implications for Affordable Care Act mandated community health needs assessments and can in some locations exist between local health departments and communities, although I think that has seen a lot of improvement. We also have funding mechanisms that are disease-focused. But well-being and health in communities is not always defined by particular diseases. And also we see funding mechanisms that don't support the kind of sustainable partnership building and work and infrastructure that needs to be in place, which I'll be spending some time talk about today, to support the kind of win-win partnership that can happen between that community experience and the planner and research technical know-how and methods. So despite the fact that there really has been a lot of improvement in the way that funding mechanisms have asked for better partnership, real partnership between communities and researchers, it's still very difficult to do that well. And so we really, as a field, are by and large not moved much beyond the Community Advisory Board model of community engagement. And I want to share with you today some thoughts on how we could do that, what it means on the ground to actually do that. And so what I'll share with you today is some work that I've done since 2009 in New Haven, Connecticut. For a couple of reasons. I've been back in Philly for 2 years now, and I'm doing work in Philly that is very exciting, but I think this case study gives a good example of some of the things that I want to illustrate today. And also because New Haven is one of the many, many more medium-sized cities that we have in this country that suffers from the fact that it's harder to get funding for some of these solutions. When you're a city of 130,000, it's hard to convince the CDC that you're worth that large grant, that large planning grant, because they just don't see the impact as well as they would in a place like Philadelphia. And yet, for those of you who know New Haven and know Connecticut, it's one of the most disparate societies that I've ever had the pleasure of working with. Connecticut's one of the wealthiest states in the country. And New Haven and Bridgeport and Hartford are actually three of the most low incomes, three of the poorest cities in the country. And of course, those socioeconomic disparities are very racialized. There are many kinds of statistics that I could share, like this disparity in wealth between black and white headed households in Connecticut. As a result, Connecticut, in the 2009 National Assessment of Educational Progress, Connecticut was found to have the largest disparity in educational outcomes between rich and poor. And so what ends up happening is that, of course, there are concentrations of disadvantage in certain neighborhoods, in certain cities in Connecticut, and focusing on New Haven, the disadvantage is concentrated in 6 neighborhoods. The disparities seen statewide are seen in the greater New Haven region. New Haven is the little black outlined in the middle there, and the region being around it, the very wealthy shoreline neighborhoods, for those of you who know, where a lot of Yale-affiliated folks live, are very wealthy, some of the wealthiest in the state. And then inside the urban core, it's more low income, but that's actually affected by which neighborhood. There are some Yale-predominated, largely high-income, highly educated white neighborhoods, which are outlined in blue. And then the 6 most low-income neighborhoods where all the poverty is concentrated are in red. So when I came to Yale, I had the privilege of working with the Community Alliance for Research Engagement, led by Jeanette Ikovics, which actually developed from a citywide cross-sectoral coalition and strategic planning retreat. It was intended to be a community partner to use the resources of Yale School of Public Health in a better way toward community health. And through that long process, they identified that chronic disease was the top issue of the community, and in particular focusing on the 3 risk factors most associated with chronic disease. As a result, CARE went and sought external funding, became part of the Community Interventions for Health, which is an Oxford Health Alliance project, New Haven being the only US site. And it was a very ambitious and a very multi-level process of looking at social determinants of chronic disease at different levels, at the individual, at the household, at the neighborhood, at the city level, and in multiple sectors. So home, neighborhood, environments, schools, and health centers. And trying a variety of different ways to attempt change at those levels, and then a longitudinal study to detect those changes over time. So we did a variety of things which could eat up all of the rest of our time. But I want to focus on a few major components of this work. We did a Triennial Neighborhood-Stratified population-based adult health survey, which means simply that we were trying to get a population-based sample of those 6 neighborhoods. So it was a randomized household survey of about 200 residents in these 6 neighborhoods. We started in 2009, right after the economic downturn. Again in 2012, and we actually just went into the field on Tuesday for our 2015. What I want to highlight about this is that we use validated measures and scales. We asked about health behaviors, particularly the 3 risk factors, health status, chronic disease rates. We asked a lot of questions about perceptions of neighborhood environment and walkability and safety and the like. But we also hired and trained community residents to be our surveyors. We got them human subjects certified. We got them hired through Yale HR. I'm saying this with a smirk because you can imagine how difficult that was. And those folks and field captains were those who went out into the field and did the knocking and the interviewing in both English and in Spanish. In 2012, we actually partnered with Yale New Haven Hospital, and this became Yale New Haven Hospital's Affordable Care Act mandated community health needs assessment. Same thing in 2015. In 2012, we also supplemented with a phone survey administered by Data Haven to capture all the rest of that region that I showed you in the previous slide. And in 2015, that's been expanded to be a statewide phone survey. So we focused on the 6 neighborhoods that I mentioned earlier. And then, because that wasn't enough, we also did schoolwork as well. So we did a baseline in 2009 in 12 randomly selected K through 8 schools. I don't know if any of you have heard the recent This American Life on educational disparities in our country, but New Haven school system is like the Hartford school system that was highlighted in there, and that it's a universal magnet system. So despite the fact that the schools are located in these neighborhoods, they actually draw students from all throughout New Haven and all throughout the greater New Haven region, although they are still predominantly students of color and impoverished students, so much so that the rate for eligibility for free and reduced school lunch is 90% district-wide. So what we did was a health survey, physical measures, and then we linked to school records, academic achievement, standardized test scores, absentee data, and then we linked through spatial geocoding, we linked to neighborhood data, which I should mention we also did with the neighborhood data as well. So crime data we got from the police district, Parks and Rec data, retailer data, and our own asset mapping data, which I'll talk about in a second. So we turned this into, we got funding to turn it into a randomized control trial where the interventions being done in each of the 12 schools were clustered to nutrition, physical activity, nutrition and physical activity, and no interventions. And then the thing that I most love to talk about is our neighborhood and school perimeter asset mapping, which was a partnership between, of course, our funders and the Community Foundation for Greater New Haven, which does a lot of community organizing in these 6 neighborhoods, and the Mayor's Youth at Work program, which is a youth leadership program. We hired 12 youth who are from those 6 neighborhoods and worked with them, trained them. They did our asset mapping with Magellan mobile mappers, grabbing geocoded coordinates and filling out grocery store and corner store inventories and the like, doing audits of local parks. And then the Color of Words is a digital storytelling local community-based organization that teaches youth media and digital storytelling. And so they produced a documentary of their experience. So it seems odd to not share results. I have so many slides and so many wonderful graphs I'd love to show you, but for the purposes of this, just to say that we were able to document the disparities that everybody knew existed around chronic disease and chronic disease-related risk behaviors in New Haven. Nobody had done that before, and so we were able to do that, and we continue to do it, and it's an important data source for that. And then we were also able to validate all of our findings with the phone survey, which also sampled in the same 6 neighborhoods. And all of the graphs look like this. New Haven is performing way poorer than Connecticut, which actually tends to perform better than US averages. You see the interesting result of lower high cholesterol. That's because these folks are not accessing care and are not having wellness visits and getting their lipids checked. What our map showed was a vast preponderance of corner stores and fast food outlets. There was 1 grocery store in these 6 neighborhoods, and it closed right after we did the asset mapping. We became part of the advocacy group that brought a co-op to New Haven after this. And physical activity environments. There are a lot of wonderful parks in New Haven, but there are a lot of issues of safety in them, and very few recreational facilities. Those that are city-run and dealing with budget issues are not open very often and are not felt to be very accessible by the population. Again, same kinds of disparities seen in the schools. And obesity rates that range from 35% to over 50%. Some differences by schools. The schools in the poorest neighborhoods do have the poorer outcomes. So the million-dollar question everybody wanted to know was, well, did we see any change between 2009 and 2012? And the answer is no. We have not yet seen any difference between chronic disease rates between 2009 and 2012. Would anybody have expected to see that? You'd be surprised to know how many people were just waiting to see that we had reduced chronic disease in these low-income communities in New Haven. But we have seen positive movement in diet and exercise behaviors, positive movement in perceptions of neighborhood social cohesion, which I think is wonderful and I think is related to what I'll talk about in a minute, which is the community organizing that we did. And we are currently seeking funding to look at differences at the environmental level. The schools, we've seen no change in BMI, and we're actually just now hot off the press, or not even hot off the press, but analyzing our longitudinal health behavior data. So we have broadly disseminated our results. We write a community brief for all of our findings and get it out quickly. I think Billy was talking about, immediate data needs for the community to advocate for planning and policy. So we do that. All of our findings we disseminate broadly in community briefs. We do town hall meetings to discuss the results, to present the results, to talk about next steps. We got a little bit better in 2012 and did a little bit better with our infographics, as you can see. We do data requests. As Director of Research at CARE, I spent a lot of time painstakingly creating an infrastructure to be able to run data requests for any community organization, neighborhood association, alderman, or whoever who wanted a different cut of the data than we were presenting publicly. We also presented maps and data specifically to each of the 6 neighborhoods so that their leadership could use it in the way that they needed to. We had lots of press conferences, local media coverage. We like to have our press conferences in City Hall. We presented Board of Alders, local and Connecticut legislators. Rosa DeLaura, who many of you may know, is one of our policy champions at the state level. We produced the documentary 3,000 Miles, which I encourage you to take a look at. I wish I could show it to you today, but it actually played at an APHA Film Institute and presented. It was completely done by the students who were involved in this. And of course, we have our peer-reviewed publications and conference presentations, and we have over 20 peer review articles. One thing that we did was we aligned what we were studying to the needs of our partners, and the school district and their school reform efforts were very interested in understanding health behaviors and how they relate to academic achievement. And so we tailored a lot of the studies that we did around that. But in between was this mobilization. We had on staff outreach coordinators and social workers who were working very closely with neighborhood civic associations, trying to match Yale resources and skills to their stated needs. We gave them seed grants to be able to spend throughout the year on the health issues related to diet, exercise, and smoking that was of most concern to them. And we were really trying to help them find the health agenda in what was already an existing health agenda. And it resulted in all the different kinds of wonderful programs you can see here. After 2012, when the Kresge funding for that ended, those efforts have been tied to the community improvement plan that's going on in the city. Sustaining that kind of level of community investment in community organizing was very difficult to sustain, and so it has a slightly different flavor now. But the Healthy Corner Store initiative still exists, and as you can see here, and things like the fruit orchards and things that were created as a result of that. We also had the opportunity to curate an exhibit at the Peabody Museum. And like some of the citywide policy that we were involved with, of food policy for the city of New Haven and the like, those didn't really resonate in the community. So we saw our job, our community organizers' job, was really to link these citywide efforts to the needs of the local community. that without that, they were not linked to the Complete Streets legislation lobbying going on. They were not linked to the food policy that was happening. They saw themselves as disenfranchised from those efforts, and we really tried to amplify those within the community. Just other pictures of that. We did the same thing at the school level. We had parent ambassadors. We had social marketing campaigns. We had cafeteria learning labs. We had food taste testing. We had a Health Heroes campaign. So a few things that I'd like to leave you with. The advantages of a community workforce. The benefits to our research design was that we gained entry to local corner stores, to folks in their home environments in a way that would not have happened without that. When we set out to do this, people said, nobody's going to take your survey. We proved them wrong, and those challengers have become our best assets and our best allies. We also gave training and job opportunities to those who became our community surveyors. They were human subject certified. We linked them to census and other research happening at Yale, but it was a tough fight within Yale HR. Here at Drexel, and the work I'm doing evaluating the Dornsife Center for Neighborhood Partnerships, Drexel has a workforce development officer and a desire to link employment opportunities in the community to community residents. And there's more support for that kind of alternative career trajectory for community residents with experience that is so essential to this kind of work and research. And we also, they also increase their ability to explain research, to explain health disparities and social determinants of health to their families and neighbors. So if I can leave you with this, I hope that I've touched on most of these today, but how does public health ensure community-driven community action? True engagement and partnership. That means in every phase of research and planning, in results interpretation, in advocacy and in action. Focusing on community assets and resilient characteristics my work has taken a turn into community resilience recently. And building on those, strengthening skills and capacity for community action. Not many folks have the opportunity to develop and evaluate a data and democracy, which Jared mentioned earlier, but to actually create investment in community and infrastructure for communities to be able to partner more equitably on research and planning, but also to be eventually the drivers of that community action and research. Invest in a community workforce for community action in urban health. And I don't mean to say, as I've illustrated here, just community members, but also those of us who do the work in there. I've gotten a lot of pushback from folks saying that, well, you can't make a community member a researcher. They didn't go to 7 years of graduate school like we have. But we also expect that that researchers who do work in community can quickly learn the history of a community within the context of a limited grant cycle. That's just as unrealistic in my expectation. So building our ability to work more appropriately with community. Studying community engagement over time and its impact, not just on community health indicators, but also economic and employment and other indicators. Disseminating data and research findings in creative ways so that it's immediately usable, and I think Billy illustrated that perfectly, how we can use all of these new technologies we've been talking about in this conference to provide that kind of data visualization and feedback that folks need to be able to advocate more effectively. And of course, to advocate for funding mechanisms and build the infrastructure to sustain all of this over time between projects. Because as we know, this takes time to build the trust, to build the linkages, to build the infrastructure, to be able to do this in a meaningful way. Thank you.
Any questions for Amy?
That was lovely to hear all of the work you've been doing. And I think I have a question about the very last point you made, and that is, how do we get the researchers more comfortable and open, or how have you been able to, in your work, to be able to interact and relate and become a member of a community partnership team?
That's a great question. I think as a professor, I'm trying very hard to make sure the students that work with me have the experience of getting to know an organization or a neighborhood leader, listening to them about what is of concern to their community, and finding what those research needs might be and how we could fit our skills and adapt them to what would help them. I think that there's no lack of ideas there. You know, we just need to have the space and the comfort in which to address it. But in terms of researchers that have already been working in the community, some of the work that I did in New Haven around relationships between researchers that are doing quote-unquote CBPR research in the community and then those community partners' experience of that research, is that the community folks are saying that if we don't have a conversation about race, power, and privilege, then we're never going to be able to work together well. And the researcher is saying, well, you know, that's a history that I understand and I'm not a proponent of, and so let's just get past that and work together. So I think we need to have these hard conversations to work together, and I think, you know, with sharing of resources, reporting that data back immediately and in usable ways, I think some of that trust can be built, you know, even beyond the conversation and the initial conversation. But my experience has been that there's no lack of great ideas, and they can serve both peer review, you know, and academic career trajectory goals as well as the goals of the community. It just takes a bit of creativity.
Yes.
Thank you. Great work. I'm glad to learn about it. Can you talk about how the business community interacted with your project, you know, the for-profit sector? Because we often think public health can ignore them and do this work without them.
Yeah. The part of the business sector that we most interacted with were the neighborhood business associations, who were very key partners in the community organizing going on, and sort of helped identify some of the variety of different health interventions that you saw, because if it was about, you know, donating soccer balls and that type of thing, you know, it was very, very hyper-local. But where we really interacted the most was in the Healthy Corner Store initiative, which I know a lot of folks have been involved with. I know it's huge here through the Food Trust in Philadelphia, but we worked very hard identifying those who could provide technical assistance and capacity building to the corner store owners that were just mom and pop stores, helping them to be able to provide these you know, fruits and vegetables and healthy snacks in a community that was not necessarily demanding it all the time, you know. And so we worked through the business associations, but also with those owners as well, around how they could be working with public health and with the community to try to bring to them options that they didn't formally have.
Great, thank you.
Okay, thanks.